This is the thiamine deficiency case study by Chiara Rilera, Catherine Franzak, and Brenda Torres. A brief case description consists of a 59-year-old male being brought to the emergency room by the EMS after a family member found him extremely confused, disoriented, and agitated. The patient is known to be a heavy drinker, no known medical problems, denies previous drug use, and the emergency room physician administers thiamine.
The patient presented with the following symptoms: ataxia, which is the loss of coordination of voluntary muscle movements, shown through difficulty walking and unsteady gait; ophthalmoplegia, which is paralysis of the muscles within or surrounding the eye, shown by irregular eye movements and horizontal rapid eye movements on lateral gaze; and finally, disorientation and agitation, shown by the patient's mental confusion.
The major laboratory findings for this patient were an afebrile pulse with 110 BPM, a normal blood pressure, a urine drug screen which was negative, and a positive blood alcohol level. Next to these findings, you can see the normal levels, which the pulse was slightly above normal, the blood pressure was normal, and tested negative for all of these listed drugs, as well as a blood alcohol level which, being positive, tends to be over the legal limit of 0.08.
As mentioned before, thiamine was administered by the emergency room physician. Thiamine deficiency is uncommon except in alcoholics as a result of nutritional deficiencies and malabsorption. Thiamine is normally ingested via diet and absorbed via intestines. Malnutrition occurs due to a high carbohydrate diet, which means a low intake of vitamin B1, which is thiamine. Enzymes required to break down carbohydrates need the thiamine in order for them to work. The lining of intestines are damaged by alcohol consumption, and this inhibits transport mechanisms responsible for thiamine absorption. And so high malnutrition and in high consumption of alcohol equals a low thiamine absorption.
The most likely diagnosis of the patient was said to be Wernicke-Korsakoff syndrome due to the deficiency of thiamine. Wernicke-Korsakoff syndrome is a combination of Wernicke's encephalopathy and Korsakoff syndrome. These are often diagnosed as a single syndrome due to the close relationship and overlapping symptoms between the two. Wernicke encephalopathy is characterized by confusion, ataxia, eye disorders, asthenia, and concentration and memory problems. Similarly, Korsakoff syndrome is characterized by anosognosia, which is the neurological condition often seen in dementia patients, confabulation, which is the generation of false memory, and anterograde amnesia, which means they cannot form new memories. The reasons for this diagnosis that the patient presents with is ataxia, mental confusion, and eye disorders.
The importance of thiamine. Thiamine is a water-soluble vitamin which is known as vitamin B1. It is a cofactor for enzymes that catalyze oxidative decarboxylation of alpha-keto acids to form acylated coenzyme A, also known as acetyl-CoA. Thiamine transfers an aldehyde group when transferring pyrophosphate groups from ATP to thiamine. It is also ingested by diet. Many thiamine deficiencies can cause leg numbness, dementia, gastritis, peptic ulcer disease, macrocytic anemia, also known as folate deficiency, depression, nutritional deficiencies, cardiomyopathy and pancreatitis, liver disease, and dry beriberi and wet beriberi. Thiamine pyrophosphate is known as the active form of thiamine. This is also called thiamine diphosphate and abbreviated for TPP. To produce TPP, an enzymatic transfer of a pyrophosphate group from ATP to the thiamine is required. This results in a reactive carbon on a thiazole ring, which is easily ionized to form a carbanion. Carbanions can undergo nucleophilic addition reactions, which can take place using pyruvate hydrogenase and within the citric acid cycle. Thiamine, when converted to TPP, is a cofactor that helps enzymes catalyze reactions. The enzymes that rely on TPP are pyruvate dehydrogenase, which helps produce acetyl-CoA from pyruvate, alpha-ketoglutarate dehydrogenase, which produces succinyl-CoA from alpha-ketoglutarate, and branched-chain alpha-keto acid dehydrogenase. The pentose phosphate pathway in glycolysis happens between when glucose 6-phosphate is transformed into fructose 6-phosphate. Within this pathway, TPP is required to transfer the glycoaldehyde unit from ketose to aldose. This is a reversible transformation of pentoses into fructose 6-phosphate and glyceraldehyde 3-phosphate. A deficiency of TPP or thiamine produces decreased amounts of NADPH and decreases the amount of glycose that is converted into pentose. Therefore, with this deficiency, at the end of the glycolysis, you get less pyruvate formed.
Thiamine pyrophosphate is an essential cofactor for enzymes that catalyze the oxidative decarboxylation of alpha-keto acids to form an acylated coenzyme A, or acetyl-CoA. As a cofactor in the pyruvate dehydrogenase complex, it is critical for the functioning of this large multi-enzyme complex that contains 3 key enzymes. TPP, also known as thiamine pyrophosphate, acts as a coenzyme that facilitates the decarboxylation of pyruvate when binded to TPP to yield hydroxyethyl TPP and releases a carbon dioxide molecule. Oxidation occurs with transforming hydroxyethyl TPP into acetylipoamide and the help of an exposure of dehydrolipotransacetylase helps transfer the acetyl group to the coenzyme A, and this results in the formation of acetyl-CoA and dehydrolipamide. To regenerate the fully oxidative form of lipoamide, for further rounds of the reaction, it interacts with the dihydrolipodehydrogenase enzyme, which is covalently bounded to FAD. The FAD accepts the reducing equivalents from the reducing lipoamide to form FADH2, an oxidized lipoamide. The reducing equivalents are then transferred to NAD+ to form NADH, which is regenerated via the electron transport system with the production of ATP. It's important to note a low concentration of thiamine in the body does not allow the conversion of pyruvate into acetyl-CoA, and to have thiamine present, this is important for the bridge of the processes of glycolysis and the citric acid cycle to be able to make the conversion of pyruvate to acetyl-CoA.
After pyruvate oxidation occurs, acetyl-CoA is formed. Acetyl-CoA is then combined with oxaloacetate in the citric acid cycle via the enzyme citrate synthase to form citrate. Citrate is then converted to isocitrate via the enzyme isonatase, which is an isomerase enzyme. Isocitrate is converted into alpha-ketoglutarate via isocitrate dehydrogenase. The next step in the citric acid cycle is the thiamine requiring step. Alpha-ketoglutarate dehydrogenase, which needs TPP as a cofactor, converts alpha-ketoglutarate into succinyl-CoA. Succinyl-CoA is then converted into succinate via succinyl-CoA synthetase. Succinate dehydrogenase converts succinate into fumarate, which is then converted into malate via the enzyme fumarase. In turn, malate converts to oxaloacetate via malate dehydrogenase. Oxaloacetate is once again combined with acetyl-CoA to create citrate and begin the cycle again. The flow of the citric acid cycle releases 2 carbon dioxide molecules and produces 3 NADH, 1 FADH, and 1 GTP. Thiamine is a cofactor for alpha-ketoglutarate dehydrogenase, which is the enzyme that catalyzes the conversion of alpha-ketoglutarate into succinyl-CoA. In the absence of thiamine, the production of succinyl-CoA is decreased because the efficiency of the alpha-ketoglutarate dehydrogenase enzyme will decrease. A deficiency in thiamine means a deficiency in TPP, leading to a depressed rate and flow of the citric acid cycle. Low levels of TPP will produce a decreased amount of succinyl-CoA, which in turn decreases the production of fumarate. If fumarate is decreased, malate production will also decrease, which will affect production of oxaloacetate. Oxaloacetate is needed for the continuation of the citric acid cycle because it combines with acetyl-CoA to form citrate. If thiamine levels are depleted, not only is the effectiveness of the alpha-ketoglutarate dehydrogenase enzyme decreased, but the availability of acetyl-CoA is also decreased. Without acetyl-CoA present, the citric acid cycle cannot begin. Thiamine deficiency is most frequently assessed by assaying erythrocyte transketolase activity in the presence and absence of added TPP. If the red blood cells have sufficient thiamine, the transketolase will be fully saturated with TPP, and no increase in activity will be observed when TPP is added to the assay system. An increase in transketolase activity indicates that the patient is thiamine deficient. The patient presented in this case study was diagnosed with Wernicke-Korsakoff syndrome. The symptoms presented by the patient were disorientation and mental confusion, agitation, irregular eye movements, and unsteady gait. The emergency room physician diagnosed the patient based on their physical symptoms and their history of heavy drinking. However, in order to confirm the diagnosis, the physician should have tested the patient for erythrocyte transketolase activity.
These are our references.